Hi everyone, this is your voiceover PowerPoint for your respiratory content. Again, this is pneumonia, community acquired, hospital acquired pneumonia, um, pulmonary embolism, ABGs. So what we're going to be covering in this respiratory content is pneumonia. So we're going to be going over healthcare acquired pneumonia and also community acquired pneumonia, chest physiotherapy, pulmonary embolism, and ABG interpretation. I left all the chapters on here and also the pages, that you can find the chapters on in Lewis. So a lot of content to go over, but I think you'll find it really interesting. Okay, guys, so we're jumping right into pneumonia. Okay, so what is pneumonia? That is the question. So it is an acute infection in our lungs. Okay, it's actually the 8th leading cause of death in the US, and these mortality rates are actually really directly related to sepsis. We'll get into sepsis in a little bit at the end of pneumonia, but it's a huge issue. We need to be really good nowadays with really prompt fluid administration, especially if a patient does have the diagnosis of pneumonia, and really, really prompt antibiotic therapy. Those two things are going to help our patients so much. It's going to help decrease mortality rates. It's going to help decrease septic rates. So again, we're going to get into that in a little bit. But you're going to find that a lot of patients that you tend to admit or have an admitting diagnosis have pneumonia. It's a very large group of patients. What I also wanted to talk about was our body defense mechanisms, especially that protect our lungs and help us fight against pneumonia. And I want you guys to think about that just for a little bit. So the first one is very simple. It's coughing. So we have a cough reflex and a gag reflex. And these things really, really help, microorganisms or even like particles that aren't supposed to be, going down into our lungs, even thinking of food. That cough and that gag can try to help get whatever isn't supposed to be going down into our lungs out. Okay. Also, I don't know if you remember from A&P, but we have a mucociliary escalator, or sometimes people call it a mucociliary ladder. And we have like little cilia that line our airway and help bring things up out of our body that's not supposed to be there. There's a little YouTube video that I'm going to show you guys that's going to just help you visualize that a little bit better. But, if you have microorganisms that are entering our body, particles that shouldn't be there, these little cilia kind of move the particles or the microorganisms up and out of our body. And it's a really, really helpful defense mechanism. Also, reflex bronchoconstriction. So think of constriction, it's closing tightly, whereas bronchodilation, it would be opening more and wider. So dilation, and if it's open wider, we're going to have more microorganisms coming in, right? So if we're constricting, and our body knows to do this, which is amazing, reflex bronchoconstriction. So it's constricting, our airways are becoming more narrow. It's going to be harder for those microorganisms or, anything that's not supposed to be going into our lungs. It's going to make it a lot harder for it to get into our lungs. And also epiglottis closure or reflex. So we almost have, it's kind of like a little flap on our epiglottis. And that closure or reflex really helps also microorganisms or even kind of food particles from going down into our lungs as well. So when these defense mechanisms that we just talked about, sometimes they don't work to our full potential. Sometimes age affects them, or we have certain diseases that affects, these type of defense mechanisms and they don't work as well. And that's going to make us more apt to get pneumonia. So think of that cough. If we don't have a good cough or gag, what do you think is going to happen? Probably end up with aspiration, right? So if we're choking on something and we're not really using or utilizing that cough or gag to that full potential, we're probably having particles going into our lungs, or such as fluids or food. Also, that mucociliary ladder, I just wanted to make a note. A good example is patients who smoke. So when we smoke, the nicotine and the smoke actually makes that mucociliary escalator not work well at all. It almost destroys it. So when that's not working well, things aren't going to come up and it's not going to be working to its full potential. The escalator is going to be closed down for the day. Okay. Um, it's quite amazing also. So patients who do quit smoking, I know we're getting a little off track, but just in as example of how amazing our bodies are, even after a week of a patient that has quit smoking, that mucociliary escalator kind of it starts to come back, and it starts to work again to its full potential. And that's why when patients do quit smoking or they don't smoke for quite some time, they have so much sputum coming up. I'm not sure if you've ever seen this before, but so much sputum coming up. That's the mucociliary escalator working again. So it's really quite amazing. Let's see. Also, we talked about reflex bronchoconstriction. So if that's not working to its full potential and we're having more dilation, we're just going to have more microorganisms coming into our lungs. And again, with that epiglottitis closure, that reflex, so we talked about that flap, and that flap sometimes stays open. Again, we're going to have, particles or microorganisms coming into our lungs a lot easier. Things that can also probably affect more of the mucociliary ladder other than tobacco or smoking is sometimes pollen, pollutants, chemicals, and also just aging changes in general. So there is YouTube videos just to show you guys, the epiglottitis closure, reflex bronchoconstriction, the mucociliary ladder. So I think you'll enjoy just looking at those, just getting a visual of what that is. So moving on, risk factors for pneumonia. There's a lot of them, right? So first, looking at the slide, age. So any patient that's older than 65, huge increase for having pneumonia. Chronic illnesses. So if patients have illnesses of the lung, cystic fibrosis is a good example. Heart disease, liver or kidney disease, asthma, diabetes. Also think of patients that have weakened immune systems. So patients even have autoimmune disorders, lupus, even HIV, AIDS, and cancer. That can all increase the risk for pneumonia. And we talked a lot about on the last slide of cigarette smoking. And I think we do have a really good understanding now of the mucociliary escalator and how that gets destroyed with nicotine and smoke. So if patients have any of these conditions or risk factors, it's really much easier for pathogens and like bacteria or viruses, microorganisms to enter the patient's lungs. There's also others. I'm not sure. I will give you guys just a little bit to think of maybe some others on your own. So surgery, immobility. Okay, so think about how quick we want to get patients up and walking. It's a big deal, right? We want to mobilize their lungs. If we don't do that and we let that patient immobilize and lay there, we're going to have contents in those lungs just sitting there. It gets stagnant, bacteria builds up, and therefore we have pneumonia. Air pollution. Aspiration's a big one. So patients who, have swallowing difficulties, they don't have that epiglottitis closure going on. They may have a disease process where that flap stays open. They may have had a stroke. Aging processes. So aspiration is a huge issue with pneumonia. Also gastric feedings, thinking about patients who are getting tube feeds, okay, whether it be through a nasogastric tube or even a peg tube in the stomach. If they're not even positioned properly in the bed, so think about that, their head of bed needs to be at least 30 degrees. Sometimes if we lay those patients down, was it too long to lay them down? Is that gastric contact coming right back and going right into their lungs? That's a really huge issue leading to aspiration from feeding tubes even. Intubation is a big one. We really try hard while intubating a patient to keep everything as sterile as possible. Once a patient is intubated, it's really important to keep up on mouth care, suctioning the patient. Sometimes they need just a little empirical antibiotic therapy just to make sure that they don't get the pneumonia. So those are just a few other examples or risk factors of why patients may get pneumonia. Okay, so talking a little bit more about the entrance of pathogens. So we did talk, quite a bit about aspiration. We talked about food contents, fluid, drinks, or even tube feeding products not going into the right place. So instead of gastric content going into our stomach, we're unfortunately getting some of that content into our lungs. It's very, very dangerous, and we want to try to prevent that as much as we can. Also, inhalation's a big one. So actually, like there's microorganisms that are even present in the air that get spread person to person. So the big pneumonia that, is really caused by this is Mycoplasma pneumonia, or it can be fungal also. So remember, Mycoplasma pneumonia, it's actually spread by others, coughing or sneezing. It's really when someone's infected with the Mycoplasma pneumonia. They cough and sneeze. They actually create small respiratory droplets in the air that contain bacteria. And that's how other people really get infected by this. They breathe in those droplets and then they get sick. It's also known as walking pneumonia. It really has both traits, both bacterial and viral. So just remember that a little bit about Mycoplasma pneumonia. So it has both traits of bacterial and viral, also known as walking pneumonia. And it's really from those respiratory droplets from people coughing and sneezing. That's how people get infected by inhalation. And then hematogenous spread. Okay, so this is actually from a primary infection in the body already, and then it's spread elsewhere. A good example of this can be staph or even infective endocarditis. Okay, you don't really see this happening too often. It's not a common theme for pneumonia, but it can happen. So it's from a primary infection elsewhere in the body. It spreads to the lungs. Again, what's very common is staph. A good example of this can be someone with infective endocarditis. Okay, guys, moving on. So classification of pneumonia. So we're going to talk about community acquired, also known as CAP, and also hospital acquired, the kind that we really don't want because we get really, really bad marks. Okay, so we don't want HAP. We really don't want any pneumonia, but hospital acquired it's not a good thing to have. Okay, so for community acquired, it's for patients who have not been hospitalized or have not been in long-term care facility within at least the 14 days of onset. Most common types of pneumonia for this or causing the pneumonia would be strep pneumonia, Legionella, even MRSA. We talked about Mycoplasma pneumonia and Klebsiella. So just know that these are the common themes for what cause a type of pneumonia for community acquired. And then if a patient has hospital acquired pneumonia, it's also known as nosocomial pneumonia. This has to be in non-intubated patients. We'll talk a little bit about patients who are intubated who have received pneumonia, but hospital-acquired pneumonia, non-intubated patients. This type of pneumonia will begin 48 hours after admission, and it's not present at the time of admission. Some common types that causes pneumonia, E. coli, Pseudomonas, and staph. So just remember that. So what if they are on a ventilator? Okay, there's a specific, so these are VAPs, ventilator-associated pneumonia. And typically we'll count that if they, start to show signs of symptoms 48 hours after intubation. So viral pneumonia is the most common type in about like a third of all pneumonia cases. And then there's bacterial. So viral is most common. It's about 1/3 of all pneumonia cases, and then bacterial follows that. And again, just a little talk about ventilator-associated pneumonias, also known as VAPs, VAP. That patient will show signs and symptoms about 48 hours after endotracheal intubation. Again, a thing we do not want to have or do not want to be marked on for the hospital. And then there's other types of pneumonia. Again, we've kind of talked a lot about aspiration pneumonia, but this is pretty much, I would say, very, very common. So again, it's abnormal entry of material from the mouth or even the stomach, and the contents go right into the patient's lungs. So what can increase risk for aspiration, guys? So think about this, a lot of things. Think about some disease processes or what can be happening. So seizures. So if a patient's having a seizure, they can aspirate. Head injuries, stroke's a big one, dysphagia, insertion of NG tubes with or without feedings, some typically with feedings. So with NG tubes, what do we want to make sure before we start the feedings? That we have good placement, right? And the best possible way to find that out, sure, we can aspirate contents and see gastric contents, great. We can listen, we can auscultate for a little gas bubble, but that's not always definitive, right? So we always want to get that x-ray, that chest x-ray, to make sure that NG tube is in the right position, okay, before we start any feedings. It's happened a lot before where we start the feedings and it's not in the right place, and then the patient's aspirating. Changes in level of consciousness can increase the risk for aspiration, a loss of cough and gag like we talked about earlier. A patient can vomit and aspirate. We talked a lot about tube feeding aspiration. It's not entering the stomach properly, okay? And the contents that are typically aspirated, food, water, or any type of drink, vomit, and tube feedings. Also, necrotizing pneumonia, not good, and it's a very rare complication. It's a rare complication of a bacterial lung infection, and it's typically associated with community acquired. It actually causes the lung tissue to turn into like a thick liquid mass, and lung abscesses are very, very typical with necrotizing pneumonia. The patient will end up bleeding into the airways, and there will be immediate respiratory compromise. We'll probably see a lot of like vomiting of blood, hemoptysis, and long-term antibiotics are needed and possible surgery. So it's not good. It's very rare, but not a good thing for a patient to have. So what do we want to do? So let's start to get into nursing. Let's kind of critically think here. So once classification is made, right? Like, is it community acquired? Is it hospital acquired? Is it ventilator acquired? What should we be looking at to base our treatment? Right? So what are our risk factors? We want to look at, is there any disease processes? Does a patient, has he had a history of a stroke? Do they have dysphagia? Do we notice any trouble swallowing? Where has the patient been? Have they traveled? What are our risk factors? Is age a risk factor? Are they immunocompromised? Okay, remember going back to that risk factor slide? Let's look at all this. Did they just have surgery? Have they been immobile? Have they not been coughing and deep breathing using the inceptive spirometer? When was the onset? Is it early onset, late onset? How's the presentation of our patient? Okay, how stable are they? That's another important thing that we need to look at, especially if our symptoms start in the hospital, okay? Really, anytime we get a patient with pneumonia, how are their vital signs, okay? Are they stable? Are they starting to dip a little bit in their blood pressure? Are they becoming hypotensive? Are they tachycardic? Are they showing more signs of being, kind of shocky or septic? So we need to know that, especially, is the patient in the proper position or on the proper floor to be cared for, or do they maybe need to go to step down or ICU, okay? How are their hemodynamics? How are their labs? Do they have any underlying diseases, any underlying conditions? We need to find out the pathogen too, right? So what's really, really important before we even start antibiotics, if we can get right away? Blood cultures are really, really, really important. We need to find out the pathogen to properly treat the patient. Typically, patients will be put on a, empirical, wide, broad spectrum antibiotic that should cover a lot of the pathogens. But again, it's really, really important to get that first set of blood cultures if we can, okay? Um, so when should antibiotics be started? As soon after we get that blood culture, okay? Immediately. So the first thing we want to do is draw those labs, get the antibiotic started as soon as possible, okay? Very, very important. If we cannot get that blood culture right away, if we're having a lot of trouble, we really need to notify the provider. Sometimes the provider would rather the patient have the antibiotic and not waste time over the blood culture. So it's a really, really important communication um, to have that communication with the provider to see whether or not they just want to start the antibiotics. Typically, they would. So I think we got all these. When should antibiotics be started? As soon as possible, immediately. There really should be no delay in the antibiotic whatsoever. It helps decrease mortality rate significantly. Um, it's amazing once the patient gets admitted, and for every hour we do not give that antibiotic, their mortality rate increases, I want to say by 10% each hour. So it's huge. Um, and we'll go over that a little bit more when we talk about sepsis. And then what should be done quickly before starting antibiotics is, of course, blood cultures, just so we can know the pathogen and make sure that we're on the right track for the type of antibiotic that they should be receiving. But again, like I said, if they have poor veins, if we cannot get blood cultures, even with IV therapies help, we need to have that communication with the provider, and a lot of times they'll say just give the antibiotic, but you always need to talk to the provider first. This is a pneumonia severity scale. So it's called this CURB scale, the CURB 65. So this actually helps providers um, place patients depending on what their symptoms look like and how they present. Um, so CURB 65. So C stands for confusion. U, a urea more than 7, a respiratory rate more than 30, a blood pressure less than 90, and a diastolic less than 60, and if they're age 65 or older. Okay, so it kind of gives us a little prognosis here and also where they should be placed in the hospital. So if they score like a 0 to 1 factor, so it's how many factors are present, okay? So if they only have one present factor, it's a mild pneumonia. So depending on how their comorbidities are, how healthy the patient is, what their history is, they can either go home or stay in the hospital, okay? So if you see that the arrow goes down from mild CAP, we need to consider how their comorbidity status, is, and their history. We'll go from there, and they may have to be hospitalized or not, depending on how healthy the patient is. If the patient has 2 or more risk factors involved, so say they are confused and have a respiratory rate of more than 30, then we fall into this category of moderate pneumonia. So they definitely lead to hospitalization from there. And then if they have 3 or more present, it's severe. Typically, they may end up in a step down or ICU, especially if there's 3 or more. So typically, they'll probably be hypotensive, will have tachypnea and confusion. So not a good thing. We're more on the septic level here, and we need to treat the patient as so. So this is just a good video to watch, just a pathophysiology recap of pneumonia. So, all pathogens trigger an inflammatory response. So, think about it. Inflammation causes an increase in blood flow, and that leads to really vascular permeability. And our lungs become edematous, our airways fill with fluid. Even the fluid leaks into our alveoli, and we're going to have a little bit in the next few slides a recap of our alveoli as well. But these little alveoli that hopefully expand in our lungs, they're really, really, really important for gas exchange and oxygenation. Okay. And if we have fluid in our alveoli, do you think that we're going to have that proper gas exchange and oxygenation? No, it's gonna weigh them down. They're not gonna be able to open to their full potential. We're gonna not have good oxygenation at all. So we need to fix that issue as soon as possible. That's really what pneumonia is, okay? Um, and that's what leads to patients with the symptoms that they have. So when we don't have that good gas exchange, our alveoli and lungs are filled with fluid and edema. Patient gets short of breath. They get tachypnic, dyspnea, tachycardic. They don't present well. So just a little pathophysiology recap. And this is a really good video to watch for that. And again, here's our alveoli review. Just goes over what our alveoli looks like, what kind of jobs they do, and how important they are for our lungs. So I just want to show you some pictures of pneumonia and what consolidation looks like. So if you ever hear like patchy infiltrates or whiteouts on chest x-rays, and what pneumonia looks like, these are just some pictures. So typically a feature of bacterial pneumonia is when the air-filled alveoli become filled with fluid. And we kind of just talked about that a few slides back. But of course, this obstructs airflow and gas exchange. It weighs the alveoli down, and it causes the patient to be short of breath and experience all these horrible symptoms. So if you look here, well, this would be the right lung. It's almost whited out. It's full of patchy infiltrates on the right side here. We're just going to look at more patchiness, and I don't expect you guys to know this or get tested on what a chest x-ray looks for pneumonia. I just wanted to show you what it can look like. But if you see the arrows here on this side, on the picture on the left, we have a little consolidation there. So you see patchiness. And then the picture on the right, you see the arrow pointing to a little bit of consolidation. That would be the left lung. Looks like the left lower lobe. And then just a few more examples. So on the far left here, we have just a normal visual lung field. We have no consolidation. And then as we start to get into the middle here, we have a little bit more haziness, especially where the arrows are pointing. And then scattered haziness here on the far right picture. So signs and symptoms. What do our patients present like? Okay. So typically a cough is a big one. Okay. They'll have a strong, typically productive cough. They'll present with fevers, usually and chills, rigors. Patient will be short of breath. They'll be tachypnic, so they'll be breathing fast but not taking full deep breaths. And they can also a lot of times present with chest pain. Okay, so it's like pleurotic pain that the patient experiences. So what do we want to ask ourselves as nurses about the cough? So going back to the cough. Is it productive? Is it non-productive? What does the sputum look like? Is it thick? Is it thin? What's the color? What's the consistency? What's the amount? How does the patient present? Are they confused or stuporous? Also, instead of a fever, sometimes a patient may present with a lower temp instead of a fever. They can be more hypothermic. And a lot of times, if patients, especially if they have an underlying heart condition, they may actually come in and present with an arrhythmia. They may be in like a rapid atrial fibrillation or a rapid aflutter. And I know we really haven't gotten into our rhythms yet. That's coming up shortly. But very typically, you'll see that patients that get admitted with pneumonia who have underlying heart disease will end up with this type of arrhythmia until the pneumonia clears. Okay, so they'll be in a rapid rhythm like an AFib, a flutter, and once the patient starts to get better, they'll actually kind of come onto that rhythm. So what else can we see? So other than these signs and symptoms, what else could we see in the older patient? So again, neuro, let's go through all the systems. What can we find in assessment? So we're doing a neuro assessment first. We're doing head to toe, right? So the patient, we may find them lethargic, confused, and they'll have like a high temperature or even be hypothermic and have a low temp. Cardiac, possible arrhythmias, AFib, aflutter. Make sure you feel their pulses. Are they palpable ×4? How's their heartbeat? Is it irregular or irregular? Are they tachycardic? Typically, when they're very sick, patients can be pretty tachycardic and have a higher heart rate. They may have a weak and thready pulse. That's why it's really important to palpate the pulses. Pulmonary. That's the big one, right? We want to listen to their lungs. Okay, do they have fluid in their lungs? Does it sound like they have crackles? Are they rhonchorous? Do they present as if they're short of breath? Are they using their accessory muscle use to breathe? Are they tripoding? Do they almost look like they have a little cyanosis going on, which would not be good? How's their O2 sat level? How's their cough? Are they coughing? What's their sputum look like if they have it? How's their chest x-ray look? GI, typically decreased appetite, they're not eating, anorexia, nausea, vomiting. GU, how's their urine output? They probably are dehydrated, okay? How are their kidney levels? Do they need some fluid? Are they in a little acute kidney injury because of the dehydration? So what's the urine look like? Is it concentrated? How's our BUN and creatinine? Do they have a decreased urine output? Okay. Great job, guys. So complications of pneumonia. So atelectasis, so that is actually partial collapse of the lung or a lobe of the lung, and it typically occurs from a blocked airway or pressure from outside of the lung, and the air sacs or those alveoli collapse, okay? So that pressure from outside of the lung causes a collapse of the alveoli from inside of the lung. Pleurisy, that's inflammation of the tissues that line the lungs or the chest wall. Very, very common in pneumonia. Pleural effusions, so that's buildup of fluid between the tissues that line the lungs and the chest. Fluid can accumulate around the lungs due to inflammation. That's that inflammatory response, okay? So that inflammatory response leads to a fluid accumulation. That leads to accumulation of fluid in the alveoli. It really holds up our gas exchange in the alveoli. Bacteremia is actually presence of bacteria in the bloodstream, and that's when we're leading more to a sepsis issue with pneumonia. A pneumothorax can happen, and that's actually a totally collapsed lung. So what happens here is air leaks into the space between the lungs and the chest wall, and that pressure from outside of the lung really collapses the lung and causes a pneumothorax. Acute respiratory failure. So again, lungs are so distressed, they're having trouble releasing oxygen into our blood. Again, minimal gas exchange. Think of those alveoli being weighted down by the fluid. We're not having that proper oxygen going into our blood, and we end up with acute respiratory failure and very, very minimal gas exchange. And again, sepsis, septic shock, something we really don't want happening at all, becomes very serious, very life-threatening. And it's really the presence of harmful bacteria in the blood, and it potentially leads to organ dysfunction and death. So we talked a little bit about atelectasis in the last slide, and it's a collapse of the lung. So it's a partial or complete collapse of a part of the lung. And it increases in density of the infected lung. And in this case, this is our right lower lobe. If you can see these arrows, there's a red, yellow, and black arrow, and it's all pointing to that collapsed lung here. And again, I don't expect you to know what a collapsed lung looks like, nor do I want you to know what pneumonia even looks like in a chest x-ray, but it's just nice to get a good visual. So it becomes like a triangle. So any type of collapsed lung looks like a triangular density. And in this case, it's the right lower lobe. And it silhouettes the diaphragm here. So again, in this case, our alveoli are probably either partially or totally collapsed here. And do you think we have good gas exchange going on? No, not at all. Not good. Okay, guys, so we're going to talk about a little bit about diagnostics now and really how we diagnose pneumonia. So a really good history and physical, especially that physical exam. Remember, we just went through that head to toe. So doing a good head to toe on your patient. Chest x-rays are really definitive, so they really help us diagnose pneumonia. They can show the pattern and even characteristics of the pathogen. Is there a lot of fluid going on in the lungs? It kind of shows us how much consolidation, just like the pictures we were looking at. Is it very patchy? You know, what lobe is the pneumonia in? Right upper, right lower, left lower. So it really helps us get a good definitive measure on the pneumonia. Also, it helps us rule out, is there any pleural effusion going on? Is there a pneumo? Is there any atelectasis? Stuff like that. Next is sputum cultures, really important too. If the patient can give you a sputum sample, it kind of helps us test to see what kind of microorganisms are living within the sputum, and it helps us get on a better track to what type of antibiotic or what spectrum of an antibiotic the patient would need. Arterial blood gases, ABG, really, really important, especially if the patient's really having a lot of shortness of breath and respiratory failure going on. It shows us that gas exchange going on. How bad are the alveoli collapsed? Is there a lot of fluid in the alveoli? Remember, that's where our gas exchange takes place. It helps us get that exact blood oxygen level right from the artery. It helps us also see if they're holding on to any CO2. Do they need to blow some CO2 off? Are they acidotic? It looks at that pH measurement. So blood gases helps us, shows us how we can treat the patient, okay? Do they even need to be on like a BiPAP to help them blow off a little bit more CO2? Do they need to be intubated? And we're going to get more into arterial blood gases on the end of this respiratory content. So you'll have a little bit more knowledge once we get there. Blood cultures, again, are really important. Remember, we talked about if we can get blood cultures right away, right before we give an antibiotic, so important. Again, it's going to help us figure out what type of spectrum that the patient should need for an antibiotic. and it helps us better treat the patient. CBCs are important. It really gives us that good measure of their white blood cells, how bad is their infection. CBPs as well. So especially if they're dehydrated, it shows us all the electrolytes. So if some electrolytes are off, we can help fix that. Also, kidney levels. If they're dehydrated, are they in acute renal failure? Okay, or acute kidney injury, I should say, excuse me. So if their BUN and creatinine are elevated, it really tells us that they're pretty severely dehydrated and they need some fluids. Also, next is venous lactate. Venous lactates are very, very important. It measures actually the lactic acid in the blood. Acid is actually made in red blood cells and in muscle cells. So when we see a breakdown of the lactic acid, we have some injury going on throughout the body. So when venous lactates are elevated, it shows us that they're pretty sick. So, fluids are very, very important to get the venous lactate down. Again, this is more on the septic level, and we're going to get more into sepsis in a little bit. So nursing care, this is important. So this is what we really need to know and pay attention to. So again, I know some of this is repetitive, but it's so important. Prompt antibiotics. As soon as we can, we need to give that antibiotic that the physician has ordered. Again, talking about those blood cultures, if we can get the cultures right prior to the antibiotic, that would be great. Again, another important thing to remember, we don't need to wait for the blood culture results to give the antibiotic. Once we draw those cultures, give the antibiotic right away. Again, if we're having trouble drawing those blood cultures, a lot of the providers sometimes just say give the antibiotic anyway, but again, that's the communication that you need to have between nurse and physician. Prompt IV fluid administration. This also helps decrease the mortality rate of the patient. Prompt antibiotics and prompt IV fluid administration. Mortality rate decreases significantly, and we can save the patient from sepsis. Oxygen. Okay, a lot of times these patients aren't oxygenating well. Their gas exchange is impaired. Why? Because a lot of fluid is probably caught up in those alveoli and they're not working properly for that gas exchange. So depending on how the patient presents, they may just need a few liters of oxygen and a nasal cannula. If it's a little bit severe, they may need a mask. A little bit more severe, they may need to go on BiPAP, and end result, if it's the most severe, they may need some intubation and ventilation on a vent. Pain management. Remember we talked about that pleurotic pain, that chest pain, that can be very common in pneumonia. Treatment of fever. So just giving the NSAIDs, giving some Tylenol for fever, help to bring that fever down. Breathing treatment. So opening up those airways. Bronchodilators, really, really important. Corticosteroids, it just helps us, helps the lungs get stronger. Monitoring just rest and activity. Okay, patients need a lot of rest when they have pneumonia, but again, we don't want them to sit immobile either. So just having that balance. Incentive spirometer is still really important, having them cough and deep breathe. We still want that movement in the lungs. So again, every once in a while, having that patient give you a good cough, a good deep breath, practice the incentive spirometer with them is so important. If you can get them up and ambulating a little bit, if they're well enough to, is great. And making sure that they have nutrition. We can't heal properly if we don't have the proper nutrition either. So response to antibiotics, patients should usually respond to antibiotic therapy within 48 to 72 hours. We should see a little bit, better presentation with the patient, hopefully. We want to look for signs of improvement, right? So if we can, see some decrease in fever, if their cardiac monitor or if they're having any arrhythmias, like we talked about that rapid AFib or rapid aflutter, we want to see them maybe go back into a normal sinus rhythm or at least a regular rate. We don't want that rapid rate. We should see a little bit of decreased work of breathing, so decreased shortness of breath, improves breath sounds when we listen to their lungs. We want to hear a little bit less crackles, maybe a little less bronchi, a little bit decrease in a cough and sputum, decrease in pain if they're having any pain. As soon as we can, we should try to, the physician should try to switch the IV antibiotic to PO if they're getting better. Viral pneumonia is definitely more self-limiting, tends to resolve within about 3 to 4 days. So that is pneumonia. I hope that, answers most of your questions. Again, you can always come to me if you have any questions whatsoever. Feel free to shoot me an email or we can meet, whatever you prefer. Next, after pneumonia, we're going to be going over chest physiotherapy, okay, also known as CPT. I thought this was a good place to put this, especially that we were talking about pneumonia and secretions and getting secretions up and an airway. So I thought this would be a good place kind of right after pneumonia. So this is done typically by respiratory therapy, RT, and this is for excessive bronchial secretions. Definitely patients who are having even difficulty clearing the secretions on their own. This is very, very common, especially in patients with cystic fibrosis. Chest physiotherapy is done quite often with them. There's 3 things that go along with chest physiotherapy. So there's postural drainage, percussion, and vibration. So those are the 3 things that goes on with CPT. Just some very rare complications. Just wanted to add in here that sometimes patients can get fractured ribs, some bruising of the ribs, hypoxemia, and some discomfort. But again, that's very, very, very rare. I've never really heard of this happening with CPT. So the first thing we're going to talk about with CPT is the postural drainage. So it's actually just position techniques. Depending on where the secretions are in the lungs, it's the way we want to position the patient to help get the fluids more towards the larger segments of the airway so they can get the secretions out of the body. So again, just position techniques that help drain fluid from the specific areas. It could be the left lower lobe, it could be the right lower lobe. And it's it's determined by lung assessment, definitely listening, auscultating, seeing where the breath sounds are the worst, and also looking at the chest x-ray, seeing where the most consolidation is in the lungs. So we want to drain that affected segment towards the larger airways. If you've heard of like Trendelenburg, reverse Trendelenburg, the patient's head may go down. It will help get the secretions out. Sometimes they'll put them on one side or the other, right or left sideline. Some patients cannot tolerate head down, so sometimes that sideline position is a little bit better and more comfortable for the patient. Along with postural drainage, some bronchodilators should be added just to help loosen up the secretions a little bit more. And also hydration can do the same thing. So we're really definitely trying to loosen up the secretions before we do any CPT. The position typically is maintained for at least 5 minutes, not horribly long. And during the percussion and vibration, this patient will remain in this postural drainage position. So commonly this is done about like 2 to 4 times a day, typically is the order, or if it's more severe, as often as every 4 hours. It should be at least scheduled 1 hour before meals, or if it's happening after meals, definitely 3 hours after meals. We've kind of come a long way, and instead of sometimes using hand or arm techniques for the percussion and vibration, we have newer beds that actually percuss and vibrate the patient as well. I know we have a few of those at BMC that get utilized for that. And the patient can be placed in that postural drainage position in that bed, and then the bed will vibrate and percuss. So percussion and vibration. First, we'll talk about percussion. So the patient, of course, like we talked about, should be in the appropriate postural drainage position, whether they're right side lying, left side lying, reverse Trendelenburg. And the RT will place their hands in a cup-like position, fingers and thumbs kind of held close together to create almost like an air pocket against the patient's skin. So this is used like an alternating rhythm, right and left, pretty fast, back and forth. And you'll hear some hollow sounds against the skin. Sometimes just for comfort, you can place a thin towel against the skin, or sometimes they'll wear like a cotton t-shirt, whatever is more comfortable for the patient. And then vibration. This is also used, with arm and hand techniques. It's actually tensing of the hands and arm muscles repeatedly. So if you tense your hands with your arms, your hands start to shake a little bit. So that is done in a repetitive motion, and you press firmly the hands mildly against the flat of the hand on the area of the lung, and then you just repeatedly, tense and then let go, tense and then let go. And this is just a little video showing you a patient in a postural drainage position while the RT is doing percussion and vibration on the patient. So it's a good visual just to get you to understand what that looks like. And major sepsis review, we're really going to go over this well in class. This is actually sepsis. We have a sepsis protocol at BMC, which we're going to go over in class, and we're going to go through that thoroughly. And it kind of goes over how important fluid administration is, antibiotic administration is, and how a nurse can actually help control the sepsis criteria on a patient. And it helps us actually move patients to a higher level of care if needed. So we'll go over that in detail in class. And I just wanted to go over this real quick to show you what a saddle emboli looks like. This is known as a, what's the word I'm looking for? A massive PE, okay? So when we hear the word massive PE, sometimes we think of size of the clot. It's not always the size, it's just where the PE is located. And the saddle emboli is really, really bad. Because if you look, we have our bronchioles that break off into our left and right bronchial trees. And that saddle emboli blocks both. Okay, so if you think about that, are we getting any oxygenation at all if we have that saddle emboli? And think of it as just the shape of a saddle on a horse. Okay, it occludes both sides. It goes over both sides of the horse. It's going to occlude both sides of your bronchial trees. It's really, really bad. It's something that we need to take care of immediately. It's in a medical emergency. So this is just a good video on giving you a visual of a saddle emboli. So risk factors for PE, immobility, reduced mobility. So especially for patients that maybe have had surgery and they're not up and walking right away, they're at huge risk for PEs and blood clots. So that's why it's so important to get these patients up and walking. Surgery that we just talked about, okay, that increases our risk of PEs because they're immobile. Any history of DVTs brings a patient at higher risk for a PE. Cancer, it really definitely leads to a lot of blood clot issues and PE issues, especially when there's high levels of malignancy and spreading of cancer throughout the body. We tend to have a lot of PE cases. Obesity, oral contraceptives is a risk factor. Smoking, prolonged travel. That's why it's important to get up and take breaks and walk around every once in a while. Pregnancy, we talked about that amniotic fluid. Clotting disorders. Age is a big one too. So they say actually for every 10 years after the age of 60, our risk doubles. So 60 to 70, it doubles. 70 to 80, our risk doubles. 80 to 90, it doubles, and so on. Signs and symptoms of a PE. Okay, they're pretty scary. Short of breath, sudden shortness of breath. A lot of these symptoms that happen with a PE are sudden. So that's kind of a clue and a red flag for you guys to think about, that if your patient all of a sudden has that really horrible short of breath issue and also chest pain, that should give you a red flag right here. Sometimes diagnosis can be difficult with PEs. Some patients present differently and it can be varied. Also, sometimes manifestations can depend on the size of the clot or where the clot's located, and sometimes even the type of the clot. Is it a blood clot? Was it a fat deposit? Is it air? Sometimes, like your smaller clots can be more vague, and the symptoms sometimes can go undetected for a little bit. And then all of a sudden they can have a symptom and then it goes away. So we call that transient. So these symptoms can be transient, especially if the clots are small in the pulmonary system. But again, most typical, a lot of patients have that sudden onset of symptoms and they tend to decompensate extremely quickly. So that's why we really need to care for these patients in a very prompt manner. So again, dyspnea is the most common, extreme shortness of breath. You'll see their O2 sats plummet, so they'll have hypoxemia. They'll start breathing really, really fast just to try to catch their breath and try to catch up on that gas exchange, so they'll have some tachypnea. Tachycardia, so our heart rate will increase, especially if our pulmonary system's working a little bit harder, trying to push oxygen out to the body. Our heart's not getting the proper oxygenation, so our heart's going to work a little bit harder. They'll be tachycardic. Chest pain's a big one. So shortness of breath and chest pain, that sudden chest pain feeling, definitely signs of a PE. These are not so common, like a cough, syncope, maybe. Hypotension is probably another big one, especially, if they're decompensating pretty quickly. And really what's common with PEs as well is they're going to have that sense of impending doom. They're going to feel like they're going to die, and they say it. And it's a very scary feeling for the patient. So some severe complications that can go along with PEs can be a pulmonary infarction. Um, so this is actually death of lung tissue. So think of MI, myocardial infarction. It's actually death of heart tissue. In the other case, this is death of lung tissue. So this is definitely caused by an occlusion of a large or medium-sized PE, more than 2 millimeters in size. So there's no blood flow getting to that certain blood tissue wherever that clot may be in the pulmonary system. So there's insufficient blood flow from the bronchial circulation. This can happen a lot if there's pre-existing lung disease with these types of patients. It's good to know. I mean, mortality rate, 10% of patients with a PE die within the first hour. They go into an arrest. So that's why this is so prompt, and we need to care and treat the patient immediately. Does anyone know what type of arrest these patients typically go into? If you've heard of PEA, pulseless electrical activity, we'll see this a lot with patients who are decompensating and arresting from a PE. It's easy to remember because PE, PEA, so it's kind of got the same kind of acronyms. They stand for different things, but it's got the P and the E in the word. We'll get more into this, but anticoagulants need to be given in a timely manner to decrease mortality rates. That's our goal. Hopefully the patient will be able to have an anticoagulant. Hopefully a lot of patients have just gotten out of surgery. They're not candidates for an anticoagulant, which will cause huge bleeding and even more of a disaster. So we really need to take a look at, can they be anticoagulated? Can they receive, a type of anticoagulation? And hopefully they can. So this type of infarction, with pulmonary infarction, actually results in alveolar necrosis. So the alveoli actually die. Which, what do our alveoli do? They're responsible for gas exchange. Okay, so if those are dying off, we're in a bad spot here, and we're not having good gas exchange. Because of the alveolar necrosis, we actually start hemorrhaging. And even this necrotic tissue can become infected, and we end up almost with abscesses in our lungs. So pulmonary infarction is not a good thing. Diagnostics. Okay, so we got a lot of diagnostics for a PE, and a lot of them are really important and need to be done in an emergent manner. So a good H&P. Okay, what's our history? Did they just have surgery? Are they a typically immobile patient? Is there obesity? Do they have a history of blood clots? What's their family history look like? Okay, and that good physical exam, especially that pulmonary exam. Okay, do they have the chest pain, the extreme shortness of breath, that impending doom? What do their symptoms look like? Okay, chest X-ray is great, but it really doesn't help us diagnose a PE. I wouldn't make that an emergent thing. Ultrasounds of the bilateral lower extremities if there's time. So if we're more in an emergent situation where the patient's decompensating, we're really not going to have time to take that ultrasound of the bilateral lower extremities. It's good to do something maybe after, once we've treated the patient and they're more stable. We'll take a look at the ultrasound of the bilateral lower extremities to see if maybe they did have a clot in the lower legs and it had traveled up, just to see where the origination is from. But if you're in more an emergent situation, probably not the best idea at the time. Definitely getting them on a monitor when they're having these symptoms and they're decompensating. We want to get them on that continuous ECG, EKG monitoring. Um, even hooking them up to that emergency cart monitor, putting some pads on isn't going to hurt. Um, it'll only, help you in the long run, especially because it's so common to have that arrest within the first hour of a PE. It's really good to help to get them on that life pack. Arterial blood gases, they're a good thing, right? Especially if we're not having that good oxygenation through our alveoli, if we're having that impaired gas exchange. We can see how bad that is. Again, not too emergent at the time, but something that we can do. Echocardiograms are actually pretty important if we can get one. Does anyone know why? So when we have PEs in our lungs, what side of the heart do you think it causes decompensation? It's making your heart work a little bit harder. The right side. Yeah. So if we think of our AMP and how the blood flows through the pulmonary system into the heart, we're going to have right ventricular strain. Okay, so the right ventricle is going to be enlarged. Um, it's going to show a lot of strain on an echocardiogram, and that's really a definitive measure and a helpful diagnostic that there's probably a PE. Okay, so right ventricular strain, it helps us identify patients at risk um, for deterioration and that there's a PE. So that heart muscle on the right ventricle will look deformed on the echocardiogram. Um, so there's definitely an elevation of right ventricular afterload, okay? That's what a PE does. It causes right ventricular afterload. It's working too hard. It increases right ventricular wall tension. It leads to dilation and dysfunction. And we can see that right on an echocardiogram. It actually causes decreased right coronary artery flow, and it increases myocardial oxygen demand. Okay, so we're going to have deformity of the right ventricle. We call it right ventricular strain. So just know that, please. Chest CTs are the best. So we're going to get that CTA. It's a CT angio. So they need contrast for a CT angio. Okay, so we're going to want to light up the bronchioles and see where that PE is. It's going to help us see where that clot is and where they're not getting the correct blood flow. CT scans are the best definitive measure for a PE, without a doubt. Okay, so if we're in a real emergent situation, we need to get that patient down to CT as soon as possible, ASAP. Okay, we want to make sure that they have 2 large bore IVs where they can push through the IV contrast, and we want to get that picture, and we want to treat them as soon as possible after that. Something that's less emergent, it's called a ventilation perfusion or VQ lung scan. And this is a scan, that we can do, especially if a patient can't have that contrast media. A lot of patients do have an allergy, or some patients do have an allergy to the contrast. So this is where that perfusion scan comes in handy, and it's done in 2 parts. So there's a perfusion portion where an IV injection of what is called a radioisotope is injected into the patient, and the scanning device will measure the pulmonary circulation. And then there's the ventilation portion of the scan where the patient will actually inhale a radioactive gas, and scanning will look at the distribution of gas throughout the lungs. Again, we need to think about the patient's status. You know, are they more cooperative? Are they awake to do this? Or are they deteriorating and they can't, you know, some patients may be intubated. They can't do this on their own. So we just need to think about the patient's status and how stable are they. So it's just another option. It's not an emergent option, but it's a diagnostic. And then labs do help a lot. You know, they're not definitive, but they do help. So talking about a D-dimer, so if a patient does have clots in the lungs, um, there will actually be a clot breakdown of fragments. Okay, so a D-dimer actually picks up clot fragments. So it'll be elevated once it starts to pick up those clot fragments in the blood. They're known as fibrin fragments because there's clot degradation. Okay, so the D-dimer will be elevated typically, and all that's doing is picking up fibrin fragments from the clot. Okay. Troponins really important too. It actually just shows us that there's some injury going on, especially, you know, if we're having that heart strain, it's gonna show increased injury to the heart, and that's what troponins pick up. Pro-BNPs will be elevated, also known as natriuretic peptide level, BNPs, pro-BNPs. So it's really important to get a D-dimer, a troponin, pro-BNP. And I just want to make sure. Okay, moving on. This is just an echocardiogram to show you a good visual of what right ventricular heart strain may look like. And then moving on to a little bit of drug therapy that helps with PEs. So typically patients will be placed on an IV heparin drip. If you haven't had one of these yet in clinical rotation, hopefully you will, but it's a protocol-driven therapy. It's an IV therapy. It's typically weight-based of the heparin, and the nurse actually monitors labs every 6 hours to make sure that the patient's getting a therapeutic level of the heparin drip. Okay, and this is just going to help, you know, dissolve these clots, break apart these clots, have the blood run a little bit better through our circulatory system. Does anyone know the lab that we monitor for a heparin drip? PTTs, prothrombin time. Okay, so we're going to take these every 6 hours, and depending on how the lab level comes back of the PTT, that's how we base our rate of the heparin drip. Okay, so it's protocol driven. Hopefully you'll get to see this in clinical, get your hands on it a little bit. Once the patient starts to become therapeutic, we want to see at least 2 therapeutic PTTs. We can hopefully start to bridge the patient to off of IV therapy more to a sub-Q level medication. So the patient can get a sub-Q heparin, or they tend to get a sub-Q Lovenox. Okay, both anticoagulants. And hopefully from there, they'll get to the next level and we can bridge them to either, you know, a PO dosing of Coumadin, also known as warfarin, Abixaban, or Eliquis. Those are kind of the 2 most common. And again, this is once therapeutic PTT levels are met. For Coumadin or warfarin, what do we need to monitor closely for that medication? INR levels. So they need to be within a therapeutic INR level. With Coumadin, patients who go home on Coumadin at least need to be monitored weekly to make sure that they're receiving a therapeutic blood level for that. Eliquis, sometimes patients who are more busy, who don't have time to take weekly blood levels, the provider may put them on Eliquis. They do not need to have any therapeutic level with that. So that's just the difference between the two medications there. But, it's provider based. They'll choose what's best for the patient. If they're a little bit more severe, the PE, we want to do tissue plasminogen activator if you've heard TPA. Okay, so this is it can be given IV push, also IV piggyback. It's actually a fibrinolytic agent, so it's going to dissolve the clots. Actually happens pretty quickly. This is also given for patients who have ischemic strokes. Okay, helps dissolve the clots in the brain. So if you think about that the same way, we need to get that TPA in the patient as fast as we can. So for PEs, there's really not much we can do without drug therapy. We can help with the diagnostics all we want as nurses, but if these patients aren't getting the medication that they need, they're gonna die. Okay, so we're gonna have really increased mortality rates. So drug therapy is really, really important for these patients. We need to dissolve these clots. Okay. So what do we need to monitor if patients, go home on an anticoagulant? What are we monitoring as nurses, and what do we want to educate patients? Yeah, signs of bleeding, right? So we want them to be really aware of what increased signs of bleeding may be. So if we see any increase in bruising or any hematomas, or if they have any IV sticks and they're bleeding profusely from the IV, those are all things that the patient needs to know and pay attention to. We want to teach them also, brushing their teeth. We want soft bristle toothbrushes, right? We don't want to vigorously brush our teeth. We want to be careful with their gums. We can have bleeding gums. Even blowing their nose, they can cause a nosebleed. Things like that to educate the patient. Also, we talked about what they need to monitor, especially if they're going home on Coumadin. They need to have weekly levels of INR. How about diet? Something that they should be careful eating. Want to be really pay attention to foods rich in vitamin K, right? So especially those green leafy vegetables, we don't want to nix them out of their diet, but they need to just have them in moderation and just be really, really careful about eating the green leafy vegetables. Again, Eliquis is not something intended to be monitored. So it just depends on patient lifestyle, what the provider finds best for the patient. And then some patients can't be on anticoagulation, which is kind of hard. So we kind of sometimes run into surgical therapy. So we're going to talk a little bit about that. So this is more in hemodynamically unstable patients with more of a massive PE. Remember we talked more about that saddle emboli, that massive PE where it's blocking both bronchioles and affecting oxygenation in a huge way. And also when thrombolytic therapy is contraindicated. So there's a pulmonary embolectomy. So it's pretty much going in surgically and removing that clot. So it's surgical removal of the emboli. It's used in more of like a vascular catheter approach. So sometimes they'll go through the femoral artery. Sometimes they'll go through the carotid. And getting rid of this clot right away, of course, is going to decrease that right ventricular afterload, right? So we're going to have a decrease, what we talked about, that right ventricular heart strain. So we're trying to make the patient as stable as possible. I wanted to put a video just so you have a visual of what these therapies look like. Just have a visual on the surgical therapy. So there's a video for pulmonary embolectomy. Then there's a percutaneous catheter embolectomy. This is more new and, moderately invasive. And again, the percutaneous catheter embolectomy is for high-risk patients for when anticoagulation is contraindicated. So they just pretty much go through the catheter, take the clot out right through the catheter. There's a video on that. There's endovascular ultrasound delivered thrombolysis. So not only are they going in and trying to take out the clot, they're actually going in and injecting a thrombolytic, a medication around the area as well to help dissolve the clots. So that's done by vascular ultrasound. And then IVC filters are actually very common. So this is with patients who have a history or a high history of DVTs. So this video is very nice. It's an inferior vena cava filter, IVC filter, and it prevents migration of clots into the pulmonary system. So it actually is placed via a catheter. Again, it can go in through the femoral artery, it can go in through the carotid artery. And once it's in that vena cava, it opens up like an umbrella. It actually looks like, I don't know if you're going to understand what I'm saying, but there's like this scalp massager that has wires with little balls on the end. It almost looks like that, and you'll see it in the video. But it helps catch if there's any clots coming through the pulmonary system. It's gonna catch those before it hits the lungs. Okay. Some things that can happen with the IVC, which is very, very rare, is a misplacement of the filter. It can migrate to a different location where we don't want it to be, or there can be a perforation. But again, very rare. So kind of getting more into nursing, so management and care. What are our goals, right? We want to, oxygenation is first, right? We want to make sure our patient is getting adequate oxygenation and perfusion. And we want to decrease and remove the clots, okay? So if oxygenation is primary, we want to provide oxygen to the patient. And how unstable are they, okay? Will they be okay on a nasal cannula? Do they need a mask? Or do they need intubation and to be on a ventilator? We want to prevent any emboli from entering the pulmonary system from the upper or lower extremities. Run through our diagnostics, right? We had a huge list of diagnostics. Also, is our patient hemodynamically unstable, or do we have time to do a little bit more diagnostics? So we need to figure that out and communicate that with the provider, okay? So they need to be sent down to CT emergently. Can we grab those labs right away? Stuff like that. So run through every single part of our diagnostics and make sure that we can get as most of those done as possible. Is the patient so unstable that they need intubation, mechanical ventilation? Okay, so again, oxygenation. IV fluids. You can set up some IV fluids. If they're decompensating, is there a need for any vasopressors? Do we need to get this patient to the unit, to ICU as soon as possible? Early prognosis is key. It really helps decrease mortality rates. It helps decrease that arrest within the first hour, and helps, again, like I said, decrease the mortality rate. And if they can have anticoagulation and thrombolytics, we need to give that medication as soon as possible. A lot of this medication is given on ICU. Guys, typically when we do have this PE situation, this is a MEC team call, okay? So that CCU nurse, the charge nurse, they'll come down, they'll kind of take over the care of this patient. Typically they'll be brought up to the ICU, but it's just really good for you guys to know this, okay? So nursing, okay, what do we need to do? And this is really, we have a patient with a PE, okay? We can care for patients who have, low to moderate PE risk. They have smaller clots, they're hemodynamically stable. We tend to care for them more in med-surg, on the tele-neuro unit is fine. As they get more unstable or more massive PEs, that's when they go to ICU. So this is kind of more management for a patient that has a mild PE. So bed rest, okay? What do we want to do with that head of bed? We probably want that up at least, semi-Fowler position, just to get that good oxygenation, right? Vital signs, making sure that we're hemodynamically stable, they're not tachycardic on us, they're not hypotensive, okay? ECG monitoring, so we definitely want them on a tele monitor. Oxygen therapy as ordered. Provide fluids for the patient. We want to monitor labs. What labs are we looking at? Especially for diagnostics, again, we're looking at troponins, proBNP, D-dimer. If they're on anticoagulation therapy, what do we want to look at? So if they're on a heparin drip, PTT. If they're on Coumadin, they've been transferred to a PO Coumadin, we want to look at INR. We want to also prevent DVTs from happening in the first place, right? So that's a big deal. And we'll go over that in a little bit. And if they're on any anticoagulation therapy, what do we want to monitor for? Signs of bleeding, right? So hematomas, bruising, bleeding from the gums, bloody nose. Why are fall precautions so important with patients on anticoagulants? Yeah, if they fall and hit their head, we have a huge issue because we may have a bleed in our head now, and we're going to have a bigger issue than we have already. Okay, so maintaining fall precautions, making sure the patient doesn't get up on their own, especially if they're unstable or unsteady. We probably should also be getting lab draws for platelets. Okay, it helps us if we're having any thrombocytopenia going on, if our blood is getting a little bit too thin. That'll help us there. So can we think of any preventative measures as nurses that we can do to prevent any DVTs? And let's go to the next slide, see if we got some of them. So turning and repositioning, if you said that, you're correct. Coughing, deep breathing, ambulation, being on that, low molecular weight heparin, so that sub-Q heparin we tend to put all our patients on when they get admitted. It's important. We want to keep their blood a little bit thinner than normal, okay? We want to prevent any clots. So that sub-Q heparin, sometimes depending on the patient, they may need to be on a sub-Q Lovenox. SCD boots. And this is a great video we're going to go over in class. It's a PE case, and I think you'll find this very interesting. It's actually a patient who has a saddle emboli, and you'll actually see what that looks like. All right, moving right along, guys. So next is arterial blood gas, also known as ABGs. So blood gas values, what do they tell us? Why are they so important? So they're going to measure our exact blood levels of oxygen. It's also going to measure our carbon dioxide levels and our acid base. So these lab values, they give objective information about our patient's acid base status, and it can be very important, especially to how we want to provide care to our patient. So it can let us know if there's any possible underlying cause of imbalances, of an acid imbalance, especially between our pulmonary system and our kidneys. How does the body regulate pH? It identifies any acid-base disorders. And can the patient compensate for these disorders? So is our body trying to fix these issues, or is it not? So healthy individuals and healthy lungs help move oxygen into the blood and push carbon dioxide out efficiently, right? So that's kind of basic A&P that we learned. So that's inhalation and exhalation. And really that's gas exchange, and this is what we're measuring and how well it's going on in the patient's body. So you guys need to know this. You need to memorize this. Okay, so these are normal, healthy values of ABGs. So again, we're looking at the pH, and these are values of 7.35 to 7.45. CO2 is normal, 35 to 45. PO2 is 80 to 100. HCO3, also known as bicarb, 22 to 26. And on our ABG levels, we do get that O2 saturation that we also find from our finger probe. And that reads, as we know, the levels that we like to see on our O2 sats is 95 to 100%. So we need to go over what these levels mean, right? Okay, so pH. So this is used to measure the acidity or basicity of the blood in the body. PaO2, this is actually the partial pressure of oxygen, so it's measuring the exact amount of oxygen in the arterial blood. And it's a very efficient way to show how the patient's oxygenating and how the oxygen is being transported from the lungs into the blood. PaCO2, so here's our carbon dioxide, okay? So this is partial pressure of CO2, carbon dioxide, and how efficiently CO2 is being removed from the body. Remember, HCO3 is bicarbonate. It's actually a form of carbon dioxide, and bicarb is typically eliminated when CO2 gets exhaled out, okay? And then the SpO2, we know that that's pretty much our oxygen saturation of what we read on the monitors. And this is to what degree the hemoglobin is saturated with oxygen, okay? Just to give you a visual of how we draw an ABG is good. So this is a YouTube video that we're going to look at of how respiratory therapists draw arterial blood gases. Also note that if a patient is in a more critical condition in CCU, we typically insert arterial lines. And patients don't need to be stuck when they have arterial lines. Blood gases can be drawn right from that arterial line. But this is what we typically see when an ABG is drawn. So we got some steps here, and just don't get too nervous. Don't get too upset. You guys will get this. It's a little bit harder concept to understand ABGs and what's going on when they're off, but we're going to go through some steps here. So step one, we always want to look at the pH first, okay? So is our patient acidotic or alkalotic, okay? So this is why you need to memorize these lab values, because if our pH is less than the 7.35 value, the patient is acidotic. If the pH is more than the 7.45 value, the patient is alkalotic. If they're in that range between 7.35 and 7.45, it's normal, okay? So if they fall below, acidotic. If they go above, they're alkalotic. So if you get a pH back of 7.26, what are they? Acidotic. And if you get a pH back of 7.51, they'd be alkalotic. What is 7.39? That's normal. Good. I think this will help you guys a lot. So it's just showing you which way is acidic and which way is acidotic. So we have right in the middle of the green, we have a pH. Again, our levels are 7.35 to 7.45. If we are less than 7.35, we're on the acidic level, and if we're more than 7.45, we're more alkalotic. Here's our PaCO2, our carbon dioxide. pretty much showing the opposite, right? So if we are more than 45, so on the higher side, we're going to be acidotic. If we're less than 35, we're going to be more alkalotic. And our bicarb, this kind of follows more of the pH theme. So if we're less than 22, we're going to be more acidic. And if we're more than 26, we're going to be more alkalotic. Okay? This is a great slide to memorize. Step 2. So we looked at the pH first and we figured out if the patient is acidotic or alkalotic. So now we need to determine if the issue is either respiratory or if the issue is metabolic. Okay, what value would we be looking at if we are considering respiratory issues? PaCO2, partial pressure of CO2, carbon dioxide. And if we're looking more for a metabolic issue, what value are we looking at? The HCO3, also known as bicarb. So remember, the PaCO2, the carbon dioxide, is regulated by the lungs, and if that value is off, that would mean that we have a respiratory issue going on. And if we're looking more at the level of HCO3 or bicarb, if that's more off, then we're going to be looking at more of an issue of metabolic, meaning there's an issue in the kidneys, okay? So it's that balance between respiratory and kidney. If the PaCO2 is abnormal, meaning outside of our normal range, we're going to have a respiratory issue, right? And if that HCO3 or bicarb is abnormal or outside of normal range, it means that we have more of a metabolic issue. Great. Always remember that respiratory is actually opposite of metabolic. Always remember that. So if we take a look at this down here, we have PaCO2 over 45 is acidotic. PaCO2 less than 35 is alkalotic. Okay? And that's actually almost the opposite of pH too, right? So if we're on the lower scale of pH, we're acidotic, whereas if we're on the higher scale of PaCO2, it's acidotic. Okay? So we're opposite of pH and bicarb here when we're considering respiratory issues. Looking at bicarb, our range is 22 to 26, right? So if we're below 22, the patient is acidotic, so that's kind of more along the lines of how our pH runs. And if our bicarb is more than 26, we're alkalotic, okay? So this is a big memorizing game. So we need to memorize these levels, and we need to memorize, you know, the spectrum of below or above as well. So let's test our knowledge a little bit here, okay? So we're starting off pretty basic. So we have a pH back of 7.26. We have a PaCO2 or carbon dioxide of 51. And we have a bicarb or HCO3 back of 25. So what do we need to look at first? Our pH. So we're 7.26. So what does that mean on our scale? Okay, our patient's acidotic, okay? It's lower. Now, are we dealing with a respiratory or metabolic issue? What's off here? Our respiratory level, definitely. PaCO2 is 51. So what would we call this? Respiratory acidosis. So looking at these blood gas levels, our patient is in respiratory acidosis. Okay, our pH is acidotic. We have a respiratory issue, respiratory acidosis. All right, another one. We have a pH back of 7.22. We have a PaCO2 back of 38. And we have a bicarb or HCO3 level back of 19. So what do we want to look at first? pH. We want to see, are we acidotic or alkalotic? Definitely acidotic. Now, is it respiratory or metabolic? Yeah, our HCO3 is 19. So what would we call this issue for our blood gas? Metabolic acidosis. Good. And then step 3, this is where we get a little bit more complicated here. We're not quite done yet. It's great that we know our values and that we can tell if we are in metabolic or respiratory acidosis or alkalosis. But we need to also know if our body's compensating or uncompensating, okay? So always remember, bicarb is a base, so it's always going to try to neutralize our acidity. So if neither respiratory, known as our carbon dioxide or PaCO2, or bicarb is out of range, that would mean that it's an uncompensated blood gas level, okay? So always remember, when there is a respiratory problem, also known as PaCO2, our body will always compensate with an out of range bicarb, okay? HCO3 will be off. When there's a metabolic problem, HCO3, our body will always compensate with an off reading of a PaCO2. Okay, so it's the opposite. So we want to know if our patient is fully or partially compensated, okay? To know this, we always need to look back at the pH. So if the patient is partially compensated, this is a great YouTube video that kind of shows us the basics of ABGs. We're going to go over that more in class.